And also our field is changing significantly in the last few years. One of the big change and what we are looking for the further improvement is transplant oncology field. So today I would like to talk about transplant oncology. So what is transplant oncology? This is just terminology. This is nothing new. Everybody knows that we can apply transplant for the cancer patient. It's old idea. It's liver transplant to HCC. Even Dr. Sazo did transplant for HCC. So it's nothing new. But it's an interesting thing. Once somebody defined the term, it starts working by itself. So transplant oncology is now kind of a new word. Everybody is looking for what is that. So briefly, the idea is very simple. Just applying transplant surgery to the oncology field. And as you know, transplant surgery is simple. Replace the organ by surgery. And then why it's exciting things to apply transplant surgery to the cancer field? It's simple, because transplants can provide largest surgical margin than resection. And surgically, we can remove whole tumor. We can ignore how many tumor is inside the organ. Even there are hundreds tumor inside the liver. I don't care, just take it out. And one of the beauty of the transplants is we can recover organ function as well. If the patient has organ failure, like a liver failure or kidney failure, by transplants, patient can get the better function by transplant. And technically very simple. Somebody disagree, but it's simple. Just cut, take it out, put a new one in, just connect some of the vessel. That's it. So technically pretty simple. I think some of the surgery like Brendan do, it's much more difficult. So it's technically simple. But drawback of transplant oncology, the applying a transplant surgery to the cancer surgery, is immunosuppression. This is still mandatory. And this promotes cancer recurrence. So we have to be careful when we apply transplant for the cancer patients. We have to pick up right patient and right timing. And today, I cannot talk about other part of a transplant oncology. But transplant oncology is not only transplant for cancer. The other surgery, general surgery, applying transplant technique, we call it as a transplant oncology as well. For example, ex vivo surgery, take out the organ outside of patient body and cut it, the tumor, and then give it back, like all transplants. This is kind of a transplant oncology. And also some of the kind of big tumor and using bypass and cut it off. This is kind of a transplant oncology, or some complicated vascular reconstruction. Also, we call it a transplant oncology. But today, I would like to much more focus on the real narrow meaning of a transplant oncology. I'm a liver transplant surgeon, so I would like to talk about liver transplant oncology. Again, this is nothing new. It's from the beginning of the transplants was started. The HCC is one of the most common indication. Then people apply transplant for the hilar cholangiocarcinoma and the neuroendocrine mets. Those kind of indication was kind of a classic indication. If people talk about transplant oncology, they usually talk about new indication, like a liver transplant for colorectal metastasis, or liver transplant for the advanced intrahepatic cholangiocarcinoma. I would like to talk about those two indications. I hope I can reach the ICC, but start from the colorectal mets. So liver transplant for colorectal metastasis. This is, again, nothing new. This is kind of a classic indication. In 1980s to 1990, many US center and the European center tried to do this transplant. Then they noticed that outcome is not great. The 1 year survival is 60%. 5 year survival is less than 20%. Even those early days, 5 year survival should be around 50%. And the people think, so this is not a good indication. But if we look back the outcome, actually outcome was bad because many complications. those days, people thought this is not a good indication. So for a long time, transplant for colorectal mets was a contraindication. But University of Oslo team tried to revive this treatment option. So University of Oslo in Norway. So why Norway? Why not United States? Why not in some other European country? Do you know the reason? So,
They have like very good like demographics.
Yep. Norway has a kind of a unique situation of the donor. Those days, United States or other European countries, most of the transplants, the biggest transplant indication was hepatitis C. But in Norway, they didn't have so much population of hepatitis C, but they had a good donor system. So they had a lot of donor, but they don't have a recipient. Then university also people thought, okay, if there's an organ, usable organ, but there's no recipient, why don't we use it for the cancer patient? Then they started this protocol. They started this liver transplant for the secondary cancer protocol. They call it as a SICA trial. And then they did 21 patients liver transplant for HCC. This was kind of like an all-comer protocol. The inclusion criteria was very liberal. They included patients who has only liver-limited disease. If there's extrahepatic disease, they cannot be a candidate. But if the cancer is only liver, they can be a candidate. Even there's some tumor progression by during chemotherapy. And you can see there's a lot, they apply this treatment for the very advanced cancer. The median tumor number was 8 and the size was 4.5. So they did a kind of a really real outcome of the trial. That kind of the result was a surprise to the all transplant surgeon and surgical oncologist. 5-year survival reached 60%. That interestingly, within 2 years, all patients experienced recurrence. That patient could survive for 5 years. So that is an interesting thing, and they found that why they could survive. Because the recurrence pattern between liver transplants population and the partial hepatectomy population were completely different. Most of the recurrence in liver transplant population happen in the lung. And resection patients have multiple recurrence like a liver or lungs or bone. So population, from the beginning, population is different, and but recurrence pattern is different. And even patient experience lung mets, patient can survive. They have shortness of breath, they probably need home oxygen, they may have cough, but can survive. So then they suggested to everybody, this might be not a curative treatment, but can be a life-extending surgery. Then they did a second trial. This time, they tried to find the best indication, the liver transplant for the colorectal metastasis. So they found 4 factors in the SICA-1 trial, and they tried to, they made this Oslo score. Then they make the indication much smaller, Oslo score less than 2. If they limit the patient's Oslo score less than 2, the outcome go much better. The 5-year survival reached 80%. This is actually almost the same with other indication, the liver transplant indication. And if the patient's Oslo score is less than 1, sometimes they saw that the patients get the cure even after 5 years, no recurrence. So this is kind of encourage transplant society to start this treatment. So how about in the United States? As I mentioned that the early days, the United States or other European countries still struggle the organ shortage because of hepatitis C. So United States is kind of a little bit behind comparing to the Norway or other European countries. And the organ allocation system in the United States is, we call it the sickest first. We allocate an organ for the bad liver function patient first. But this colorectal mets patient, liver function is usually not so bad. The MELD score is 6 to 40, but usually this the colorectal mets patient's MELD score is around 10 to 20. So pretty difficult to get the organ offer. And so far, sometimes HCC patients, even their MELD score is 6, we call it an exception point. They can jump up allocation list. But so far, we don't have this exception point for the colorectal mets. Instead, we have a living donor. It's a kind of a unique thing in the United States and some European countries. So we can use living donor as a source of organ. And one of the big difference comparing to the other country in the United States, we have a strict quality control system. Our transplant center outcome is always monitored and usually controlled by 1 year survival. And every 6 months, we get this kind of reports. It's like we evaluate by 5 stars, like a Michelin or Yelp or something like that. So similar. So last term, we are 4-star in the outcome. It used to be 1 more? Before it was 5, right? 5-star. But if this score goes to 1 or 2, I think Mark get in trouble. So we need to maintain this score higher. So if we, and also, they keep saying that possible we will check not only 1 year, we may check 3 years outcome. So transplants for colorectal mets, if we do the liver transplant for colorectal mets and if patient die within 3 years, our program will get in trouble. So it's kind of the many transplant center kind of hesitated to start this program. So in the United States, the first liver transplant for colorectal metastasis was done in Cleveland Clinic in 2017. My best friend, Dr. Seiho, started this protocol. He didn't get enough credit for this because he seldom show up to meeting or conference. He only goes to the HPBA, and he show up in a very early morning. Then, around 10 a.m., he go to beach. So nobody know him. Yeah. First few years, only a small number was done. But since after SICA2 trial result came out, the number significantly increased. Last year, I didn't get the whole number, but the brief results show that almost 40 cases was done. So last 2 years, almost 40 cases per year of the liver transplant for colorectal mets was done. So there are 29 U.S. centers do this protocol, but top 5 centers did more than half of the cases. Stanford, unfortunately, just did 1 case last year, but University of Rochester already did 24 cases. And many other big transplant centers already started this protocol. But California, we are the only center doing this protocol. And through my experience, I was in Cleveland Clinic. So I was with this Dr. Seiho, and we worked together, and we evaluated many patients, and we had a good relationship with the University of Rochester that shared the protocol. And we always did something, a Zoom conference about this liver transplant for colorectal mets. And both centers noticed that there are 2 types of liver transplant for colorectal metastasis candidates in the United States. The first one is oncology type. We call it the Norway type. It's kind of similar to the Norway indication. The low MELD, higher tumor burden, usually relatively younger patient. and they're kind of like a treatment naive, not getting a resection or hepatic artery infusion pump. Those kind of indication, the patient is actually easy to do transplants because its liver is pristine. There's a tons of tumor, but dissection is not difficult, and patient is not so sick. So transplant itself is a 5-hour surgery, and they recover quick. And these patients can be, but this patient cannot get the liver offer because their MEL score is low. So those patients is a good indication of the living donor. The other type, this one is kind of unique in the United States because referral pattern is different between United States and Norway. In Norway or other European countries, the HPV departments and the transplant department is usually the same unit. So they can decide a treatment plan by themselves. But in the United States, as you know, if there's a colorectal cancer patients, first medical oncologists see the patients. The colon surgeon will do some section. If they have a mets, they go to the HPV surgeon. Then sometimes go to the IL. And then after getting worse or do something, then finally those patients come to the transplant service. So referral pattern is different. So in the United States, many of the transplant candidates already got some of the treatment. Like, for example, these patients, before coming to Cleveland, they got a right hepatectomy and ablation. Then Sloan Kettering put the hepatic artery infusion pump. Then, hepatic artery infusion pump chemotherapy is famous for causing bile duct necrosis. And finally, she came to the Cleveland Clinic with jaundice. You can see her bilirubin is almost 20. ALP is near to the 2000s. So this patient's MEL score was 23 at the time of transplant. Still 23 is not high enough, but can get some of the organ offer. And these patients, after transplant, we didn't see any viable tumor, and then actually she's cancer-free for 4 years. This kind of a patient is a good indication of a deceased organ transplant in the United States. So this is the percentage of a living donor and a deceased donor. So at the beginning, more than half of the liver transplant for colorectal mets use a living donor. But last year, first time deceased donor is more than living donor. Because I will explain later, but donor allocation system changed significantly the last few years. The outcome itself is living donor is a little bit better than the deceased donor, especially in the early post-operative phase. Because as I mentioned that US unique type of patient is much more sicker because they got some treatment and their liver is sick. So those patients is much more difficult. So there are 2 intraoperative deaths in this population. That's why the early post-operative outcome is worse than the. This is the overall survival, the overall cohort in the United States. 1-year survival is 92%. The 3-year survival is 67%. If you remember SICA2 trial results, this result is worse than Norway. But actually it's not. Norway team published the long-term follow-up outcome. And they show that 5-year survival is actually went down to the 50%. 3-year survival is around the 60 to 70%. So similar to the US result. Even early stage colorectal mets patients also score less than 2. 5-year survival is like around 60%. So not so great comparing to the other indication, but still 60% in 5 years. Again, the colorectal liver mets patients, MEL score is low. So if I show that the results, there's a lot of deceased donor, people ask me how you guys can get the organ for those patients. And we check this organ acceptance sequence in those donor used for colorectal mets patients. You can see very high number. Usually we call it more than sequence more than 50, we call it as a hard to place organ. So it means many people decline. But you can see over 1,000, there's a lot of over 1,000 sequence. And actually 75% of liver used for colorectal mets patient is out of sequence liver. It means transplant center around the donor hospital decline. Then organ is almost thrown away. Then organ allocation organization contact other transplant center. Then some of the brave surgeon took it and used it for the colorectal mets patient. So if you rotate transplant service, sometimes I did this kind of thing, right? You heard about I got a liver from somewhere. That is always kind of like this kind of an out of sequence liver. I get the liver from the garbage can and use it. Because this is kind of like depend on the who got an offer. Some surgeons think this is not usable, but for some surgeons, that liver is usable. And the system is, actually, recently, New York Times accused this kind of out of sequence liver allocation recently. But this is a kind of a system issue. And the current system is good for the surgeon who is aggressive. So aggressive surgeon can take advantage in this current system. And this is a kind of as I mentioned, our transplant center is always monitored by the UNOS and SLTL. This is a organ acceptance rate by transplant center. Mayo, Arizona, they did a 300 liver transplant last year. We did only 136. They are much more aggressive. You can see their aggressiveness is here. This is national average. We are a little bit aggressive, but not like them. So especially, this is organ, hard to place organ, sequence over 50. Mayo, Arizona took most of them. But we are a little bit aggressive, but still behind Mayo, Arizona. So we have more room to be aggressive. Depend on how much aggressive the center, the center can use those kind of out of sequence liver. And also, there's a big paradigm shift is ongoing in the transplant field. Probably you guys heard about liver perfusion pump. Because of that, now we can use a lot of organ, those organ we couldn't use in the past. And also, again, around 2010, used to be the biggest kind of the candidate of transplant was hepatitis C. But as you know, around 2010, DAA came out and the hep C population decreased. So transplant candidate decreased. At that time, we thought, okay, maybe NASH will be next our royal customer. Then somebody made something drug for the obese, and then NASH population didn't increase much. We still have alcohol, but the number of the transplant candidates decreased significantly last 10 years. Instead, but on the other hand, the number of usable organ increased. So transplant wait list population is significantly decreased in the last few years. And if it's keep going down, we will be the similar situation with Norway. Even we have a liver, we don't have a recipient. Sometimes I got a liver offer, but actually I experienced, I don't have a recipient to give this liver. So the transplants organ, organ shortage situation in the United States is getting better. And this is the offer for the males lower than 15. Used to be, just 10 years ago, very small number of the males less than 15 patients got a transplant. But last few years, it's keep going up. So the liver transplants for colorectal mets candidate, usually male is less than 15. And this figure show that it means United States, the organ situation got better, and they have a good chance of getting an offer. Then last year, very good first randomized control study came out from French group. This was published in Lancet. French group did the first randomized control study in 94 patients. They randomized 47 patients to the transplant with chemotherapy and the chemotherapy alone. They eventually, 36 and 38 patients got treatment. You can see even intention to treatment population, the survival, 5-year survival in transplant population was 56%. If chemo alone, 12%. If we check the per protocol outcome, if the patient could get the transplants, survival reached 73%. The chemo alone is just 9%. There's a significant survival benefit by liver transplants comparing to the chemo alone. Interestingly, European transplant center use post-transplant chemotherapy. This is not standard in United States. This is, we have to look into more detail, and probably we should start adjuvant chemotherapy for the liver transplants for COVID. Actually, in this protocol, nearly 70% received the chemotherapy, but there is no definitive protocol, depend on patient. But this is the field we should investigate more. The European countries are a little bit running ahead of us, and they do this interesting treatments. We call it a 2-stage liver transplant. Norway team used left lateral segment from a living donor. And for colorectal mets patient, first stage, they take out left lobe, but put the living donor's left lateral segment. Then wait 1 month, 2 months to grow. Let this left lateral segment grow. Then take out the right lobe. Because left lateral segment, the damage to the living donor, to the left lateral segment, is pretty small. So it's kind of good for donor and good for recipient. Because, even some patient can get the cure by transplant, basically this is not the curative treatment. So it's kind of still a life-extending surgery. So this one is kind of like future treatment, and we would like to try this treatment in the United States also. So far, only 1 or 2 centers try this protocol. We have a living donor program, and I would like to try this treatment in the future. There's a field we have to look into more in this treatment. So the Oslo score is now kind of a standard for in the liver transplant for colorectal mets. But this Oslo score came from only analyzed from 20 patients. If you make this score from 20 patients and try to publish, people will say, "Oh, you're stupid," right? Because the score came from only 20 patients. So we have to look into more detail, and we need a much bigger number. And the United States, we have this consortium made by Dr. Roberto Hernandez, and the first report will come out soon. And we are trying to make a new selection criteria for liver transplants for colorectal metastasis. And another thing, survival benefit of a transplant. She was our patient. She came to the Cleveland Clinic from the Oregon. She was 39 years old, diagnosed colorectal metastasis, and she received 40 cycles of chemotherapy. She had 4 years girl, and she looked for the chance to survive the cancer. She came to the Cleveland, and then we tried to do the surgery, but insurance company declined this treatment. Then she sued insurance company, and a lot of newspaper wrote about her. And her MELD score, you can see her eyes are yellow. So she's a typical type B, US unique type the candidate. Even like this jaundice, because she only have jaundice, her kidney function was good and the INL is good. So her MELD score is just around 15. So we couldn't get the good organ, but somehow we could find an organ that we call her from Oregon and did the surgery. But surgery is pretty difficult. She died during a transplant. So if you rotate transplant service, you frequently see we do transplant for the 70 years old HCC patient. And those patients can get the benefit by transplants comparing to the resection. Still, they can get the survival benefit by transplant. But resection, the 5-year survival by resection is around 50%. By transplant, it's 71%. Even those two populations is different population. Basically, transplant population is better heart function, better lung function, better physical strength. The only still survival benefit is only 20%. But you could see the survival benefit by Transplant trial. If the patients get a transplant, 5-year survival is 70%, and chemo only, just 9%. Survival benefit by transplant is huge. So we have to think about what is the biggest survival benefit to the patients. This colorectal liver mets candidate can get a biggest survival benefit by transplant. So our society should think about who can get this survival benefit, not only for colorectal met. So, sorry, this one first. So colorectal mets part is done. And the other thing is advanced intrahepatic cholangiocarcinoma. This is done in the Houston Methodist and MD Anderson team. But this indication is still not so popular. Only a few centers in the United States are doing this protocol. Now the Stanfords participate in their consortium. We are ready to start this indication as well. We have a good medical oncologist, Lipka Goel, and we are trying to do this protocol at Stanford soon. The Houston Methodist team did liver transplant for the unresectable advanced intrahepatic cholangiocarcinoma. This is a little bit small, but you can see this. They apply transplant for the really aggressive cancer patient. And the outcome was not so bad. It's kind of like a very selected patients. You can see the time from diagnosis to the transplant is almost 3 years to the at least 1 year to the 3 years. So those patients is pretty selected population. But if we select it nicely, transplant for the advanced colorectal mets is one of the indication. It will be the one of the indication. And another interesting transplant oncology is transplants, small bowel transplant for the pseudomyxoma or appendix cancer. My friend Anil Bhatia, he was in Cleveland and went back to India recently. He did many of this treatment, and this is kind of a still challenging field. But pseudomyxoma, sometimes you see this kind of like a tumor, big tumor, and it's kind of exposed to this kind of ruptured skin. But for those patients, yeah, transplant can be an option for improve their life, their quality of life, and extend their life expectancy. So, sorry, I'll take home. Oh, this is not new version. Sorry. Oh, I missed the take-home slides. Sorry, this is in my computer. The take-home message is this is a new field, still developing field, and probably new thing will come in every year. So it's good to for young people, and please consider transplant to be a transplant surgeon. You don't need to wake up early morning.